All right, good morning, everyone. I'm super happy to be here. One of the other things that wasn't mentioned in my biography is I'm a proud member of CRISM. And yes, I'm going to be talking a little bit about the personality-targeted intervention for addressing polysubstance use among clients undergoing opioid-agonist therapy. So I'm going to be covering the first half, and this obviously is on behalf of all of the other principal investigators that are involved in this trial, and then Neda will pursue. So obviously, one of the things, research is costly. There's a lot of different funding that was received to be able to do this research, including initially research funding from the Quebec Atlantic node, that funded the preliminary work that I will be talking a little bit about, as well as CIHR, both in a patient-oriented research grant, as well as the actual operating grant for the feasibility trial, and now also CRISM Atlantic within the demonstration project in the comorbidity working group. And there's a lot of people that are involved in this project, so please take the time to review all of our research team and partners. And I do want to mention both Dr. Sean Barrett and Dr. Julian that have unfortunately had untimely passing, but their contribution to this research is really, really important, and we will honor their memory through this project. As well as special thanks, obviously, to our clinics that are partnering with this project. So we've heard already from the lovely Dr. Davidson, and there are clinics both in Nova Scotia and New Brunswick participating. And obviously, let's not forget our partners with lived and living experience that have contributed all along and will continue to contribute all along to this, to this project. So I'm going to be covering the first half, and I need to be very, very careful with time so that Neda is not mad at me for taking too much time. So I'm going to present a little bit of the background that has led to the actual feasibility study, and Neda will cover the actual protocol. So I don't think it's a surprise to say that we are, many communities in Canada are experiencing a crisis related to drug use, and in certain communities, more specifically, opioid use. More than 47,000 deaths within that 8-year period. That is a lot of moms, dads, sisters, brothers that have passed away every day that have been recorded from that period. And it's been a perfect storm, right, with obviously with COVID pandemic that has, initially contributed to, more challenges with using in more unsafe environments, housing crisis, and also change to the actual toxicity of the drug market. So in that context, opioid agonist therapy does wonders in terms of for the treatment of opioid use disorder, first line of treatment, buprenorphine and methadone. But there are also some limitations associated with those in the context of that toxicity market. There's, as Dr. Davidson, you don't really know what you're necessarily always using, and that does create some challenges with polysubstance use and retention challenges within the clinic, especially when the opioid agonist therapy is going to help with the opioid use, but does not always pharmacologically going to impact use of other substances. And that use of other substances is associated with increased risk also. So there is a need for comprehensive approach that can, oh my God, already? Oh wow, that's stressful. Okay, I'm going to try to speed up then. So the question is, can we do better? Could some psychosocial interventions help to address some of the challenges? And focusing on, there's been trials that have looked at that. Some have had limited efficacy. Is it because we're not maybe targeting things as well as we could? And this leads us to the four-factor model of substance use. So there's been research on this model for the last 25 years. To put it in a nutshell, to summarize it in a nutshell, there are 4 personality vulnerabilities that can increase risk of substance use as well as other mental disorders and symptoms. And those are a propensity towards pessimistic thoughts, a fear of some of the bodily sensations, of anxiety, impulsivity, that tendency to do things without thinking too much, and sensation seeking, that desire for stimulation and doing new things. So we know from the research that those vulnerabilities are associated with use of certain substances and also, different types of mental health symptoms, such as the negative thinking being associated more with opioid use, more with major depressive disorders, for example. And kind of within that pathway, that is because there are certain types of thoughts that tend to be associated with then a certain desire to use for a certain reason. An instrument was developed to try to capture this and does it very, very well with just about 20 items. And that is what has spurred basically the examination as to whether we could do an intervention that would target these personality, those individual differences, and essentially then reduce substance use and mental health disorders. So in a nutshell, it's CBT. It also includes motivational enhancement, so trying to increase that motivation. And from the trials that were done with youth, we know that this very short intervention through randomized controls trials, was associated with reductions in use for those that were using, and also prevented the onset of substance use, as well as some of those other additional mental health symptoms. So then the question was, can we adapt this very evidence-based program to the context of opioid use? And that is what brings us to the OP venture. So in order to do that, there's a lot of groundwork that had to be done, right? So Dr. Mayhew did initially some first research to see, does this model actually apply to people who use opioids and are receiving treatment in OAT clinics? And the model essentially was found to be very reflective, very consistent. And then it was qualitative work that was done to basically see, the themes, talking with people who were receiving treatment in the clinics, were the themes consistent with that model? And that also gave some really good material to actually develop the case-based scenarios that will be used in the OP venture trials. And there was a lot of discussion also with clinics as to whether this could be something that was feasible and how could it be done in a way that would work well. And that basically leads us to the last part, which is the feasibility trial. So part of the consultations with people with lived and living experiences and with the clinics was perhaps we need shorter sessions, but more sessions, that these would be done in groups with manuals. And that is essentially what has been done so far. I will leave now Neda talk a little bit specifically about the protocol.
Thank you very much, Caroline. I'll continue briefly to discuss the feasibility trial we designed to evaluate the OpiVenture program. Our development and evaluation of this program was guided by the ORBIT model, which has 4 phases, aimed at improving the systematic development, adaptation, and testing of psychosocial interventions. In phase 1, as Caroline just described, we designed the intervention based on the evidence from behavioral and psychosocial research, along with the stakeholder input. And in phase 2, which I'm going to focus on that, that's a feasibility study, we focus on examining the feasibility and preliminary testing of the intervention, preparing it for next phases, which will be phase 3 and 4. The main goal of our study, thank you. The main goal of our study is to evaluate the OpiVenture program within the OAT context. More specifically, we want to focus on evaluating the feasibility of the program protocol, but as well to assess the feasibility and its preliminary effectiveness for conducting a future large-scale randomized controlled trial. And for each of these aims, we have a specific research questions. For example, we will assess the effectiveness of recruitment strategies. For the program, we have several feasibility criteria that includes the content and boost delivery of the program. We plan to include in total 96 participants across 3 sites in 2 provinces of the Nova Scotia and New Brunswick. We will have 32 participants in each site. The number is based on the calculation to ensure we have a sufficient sample for reliable result, considering the attrition rates. To be eligible, clients must meet certain criteria. For example, they must score at least 1 standard deviation above the norm on any of the 4 personality risk factors assessed with the SERP measure. And they have to be adult and must understand spoken English, and those people with severe cognitive deficiencies will be excluded. Regarding the facilitators and staff at the recruiting sites, we will invite all involved members, and we hope we get all of them to participate in the study as well. We aim to recruit clients equally from all 3 sites to ensure the representative samples from the OAT population in Atlantic region. To inform potential participants, we will prominently display the flyers within the OAT clinics. These flyers will describe the study process and requirement generally. An interested client will be encouraged to speak with the trained research assistant located in the clinic to address any questions they may have, to be able to make informed decisions. And to facilitate and maximize recruitment success, we have our clinic leaders updated of this research regularly, and they participate in our regular research meetings. In addition, before recruitment begins, we will conduct a workshop for clinic staff, informing them about the study. This will help ensure that staff are well prepared to support the recruitment process. One factor that really matters to us is the involvement of people with lived and living experiences. So as Caroline mentioned, they've been involved in developing an adaptation of the program, but also we have to secure 2 people with lived experiences who will help us. Okay. Yeah, this is really distracting. So yeah, for having we secured 2 people that they were going to help us with reviewing the final manuals, the study survey, the interview guides, as well as helping us for interpretation of final results. We will collect data both from clients as well as involved facilitators and clinical staff, as mentioned before. For clients, we collect data prominently in 3 main data points, including baseline, 1 month follow-up and 4 months follow-up. At 1 month, we collect demographic information, administrate the SERP, personality assessment, and have participants complete an online survey. At 1 month follow-up, we ask them to participate in an individual interview to discuss the feasibility of the program, and also ask them to complete the acceptability questionnaires as well as the online survey. And finally, at the last time point, we ask them to complete the survey for the last time. Data management will be handled with a red cap, and for facilitators and directorate staff, we will ask them to attend a focus group to complete data collection. And a fidelity checklist will also be used. So to go really briefly over the study outcome measures, we mainly focus on mental health and substance use here, some of these measures are mostly talking about like measuring the frequency and quantity of the substance use and the motives for that, for example, as well as their mental health. There are some more because I don't have time, so I'm not going to more details in them. For analysis, we analyze the interview and focus group, basically the qualitative data with the thematic analysis method. To test the limited efficacy, we will use the multi-level modeling. And depending on the sample size, we will plan to conduct supplementary analysis to explore possible moderators such as sex and gender, the type of the OAT medication they use, and age group, personality type, and even the specific clinic and language. Just 1 more minute. So in terms of where we are, we did have some staff change, so we haven't started the study yet, but we are ready to start the study in coming January, February, and we expect this to take about 12 to 15 months. Depending on the finding of the study and if the feasibility and preliminary efficacy of the program is proven, we will plan for next step, which is a randomized control trial, a full-scale randomized control trial. Thank you very much, everyone, for listening. And I hope next time I get more time, specifically for people like me, that they have to translate the English first in their head and then say it in, yeah. So thank you very much.
Thank you, Dr. Brunelle and Dr. Alizadeh.